professors and dear colleagues, and welcome to join us for the Asia Pacific Stroke Islands project, which is organized and supported by the Chinese Stroke Association. And we also got the academic support from Amgen Pharmaceutical. And this series event focus on the secondary prevention and the intracranial atherosclerosis. So this is the third time today, and we got a very good feedback from colleagues from the Asia Pacific area. We would invite a couple of the experts focus on one topic each time. And also we invite a group of experts for the panel discussion after the key presentations. So today I will be honored to be invite my another co-chair, the Professor David Wang from BNI San Jose Medical Center, Phoenix, to moderate the education this morning. So the symposium were hybrid arranged, and we have the living demonstration to all the colleagues, and there will be the question and the discussion later. So I will invite David to give a brief remarks first.
Sure. Hey, thank you, Liping. It is so nice to see everyone online, especially to meet Dr. Lau from Hong Kong, right? And Dr. Wang from Royal Brisbane. And it is very nice to have experts on this panel and giving two very important talks too. This is the third session of our Asian Pacific Stroke Alliance project. I think it's very meaningful because we have talked about atherosclerotic disease, intracranial atherosclerotic disease, imaging studies, pathophysiology, what is up to now, the guidelines, how to deal with it. And today we come to the third and also very important topic, that is the lipid, the story of lipid. It seems to be never ending story of lipid. So this is seems to be a timely topic for the practitioners now times, and also for those who may be interested in clinical research, because we really have many unanswered questions on this topic. So without further ado, I think Dr. Liu, would you mind to introduce our first speaker? Then we can get started. Thank you.
All right. Thanks, Dave. David, and let's welcome the first speaker today, Professor Gary Lau from Hong Kong and University of Hong Kong. Here is the brief introduction of Professor Lau, and his main research focus on the cause of stroke, and today he's going to he's going to present the topic with a lipid lower therapy for the secondary stroke prevention. Welcome, Professor Lau.
Thank you so much for the very kind introduction and also invitation to this wonderful meeting. Just going to try and share my screen. I wonder whether you see my screen? Can you hear me?
Yes. Yes.
Wonderful. Yes. Yes. Thank you so much again for the invitation and introduction. So yes, the topic I'll be talking about is on lipid lowering therapy for secondary stroke prevention. And here, as many of you will know, are some of the very recent guidelines from the American Heart Association and the American Stroke Association. And in the coming sort of first half of the talk, I'll be focusing on some of the key trials that have led to the development of these guidelines. So first of all, on the recommendation of patients with ischemic stroke with no known coronary heart disease and major cardiac sources of embolism, the use of hydrostatic and reduce risk of stroke recurrence. Well, the evidence behind this mainly stems on the Sparkle trial. And in this trial, this was done quite a few years ago now, that 4,700 patients with TIA and stroke within 6 months with an LDL of 2.6 to 4.9 were randomized to receiving very high dose of atorvastatin, 18 milligrams per day, versus placebo, with the primary endpoint of non-fatal or fatal stroke. And here, patients with cardioembolic sources of embolism or patients with atrial fibrillation were excluded. And during a mean follow-up of about 5 years, the LDL that was achieved in the atorvastatin group was down to 1.9, and in the placebo group was about 3.3. And as you can see here, that the use of a high-dose atorvastatin was associated with a significant reduction in the risk of a fatal or non-fatal stroke, and also major cardiovascular event. And just regarding those, the small proportion that were having had intracerebral hemorrhage that were recruited in the trial, these were deemed to be at high risk of ischemic stroke or coronary artery disease upon sort of recruitment to the trial. Subsequently, several years later, the Improve It trial. There has been other trials that have been tried to determine whether non-statins, such as ezetimibe, had incremental benefit in lowering the LDL and also improvement in cardiovascular outcomes. And Improve It is one such trial, right, that focused on patients with acute coronary syndrome. And this is a large trial, 18,000 patients, right, with acute coronary syndrome within 10 days, with LDL 1.3 to 2.6. If they were receiving lipid therapy, or sort of 1.3 to 3.2 if not receiving lipid-lowering therapy. And they were randomized to receiving simvastatin 14 milligrams plus ezetimibe 10 milligrams versus simvastatin and placebo. And the primary endpoint was a combination of number of major cardiovascular events. And again, after a median follow-up of about 6 years, it was noted, you can see a drop in the LDL in patients with ezetimibe and simvastatin was about to 1.4 versus 1.8 in simvastatin-only groups. And there was a mild reduction in risk of major cardiovascular events in the combination group, with an absolute risk reduction of about 2%. There has been some follow-up analyses of the Improve It, where they further analyzed the 641 individuals who developed at least one stroke during the follow-up period. And interestingly, it was noted that the combination of ezetimibe and simvastatin noted a significant reduction in the risk of ischemic stroke compared with the simvastatin alone, right? And but there was importantly no significant differences in the risk of hemorrhagic strokes in the two groups. And furthermore, right, when patients with and without prior stroke were compared in this trial, it was noted that the risk reduction in a subsequent stroke with combination lipid lowering therapy was greatest in patients with prior stroke, as you can see in the top two lines here, compared to those without a previous stroke. And that corresponded to a significant 8.6% absolute risk reduction in those with a prior stroke receiving combination statin and ezetimibe therapy compared to 0.4% absolute risk reduction in those without prior stroke. And this results really signifies the potential incremental benefit obtained in patients on statins with the addition of additional lipid-lowering therapies such as ezetimibe, as shown in the Improve It trial. Of course, despite the beneficial effects of lowering cholesterol with statins or with the additional addition of ezetimibe, it has remained uncertain until recently as to the target LDL to achieve in patients with TI or ischemic stroke. And in the TST trial, the Treat Stroke to Target trial, this trial recruited about 2,860 patients from France and South Korea with TI ischemic stroke. Majority of them were having stroke, but with evidence of cerebrovascular or coronary artery disease. And they were randomized to two lipid LDL targets, less than 1.8 millimoles per liter versus 2.3 to 2.8. And they, to achieve this target, they can use statins with other lipid-lowering agents, and mainly ezetimibe at that time, right, to reach the target LDL. Again, the primary endpoint was a composite major cardiovascular event endpoint. And during the median follow-up about 3.5 years, those in the lower target group achieved an average LDL of about 1.7 versus about 2.5 in the higher target group. And you can see here, there was about a 22% reduction in risk with a hazard ratio of 0.78 in those who achieved a lower target group. And again, there was no noted increased risk of intracerebral hemorrhage in the lower target group. And hence, this has led to the subsequent, the other part of the guideline recommending that in patients with ischemic stroke or TIA, together with atherosclerotic disease, right, be it in the intracranial, carotid, aortic, or coronary artery beds, that lipid-lowering therapy with a statin and also ezetimibe if needed is recommended to achieve a target LDL of less than 70 milligrams per deciliter or less than 1.8 millimoles per liter to reduce the risk of major cardiovascular events. Well, interestingly, when looking back at the TST trial, as mentioned, it involved patients from France and also patients from South Korea. The majority of them were French, 2,000 of them from France and about 700 from South Korea. The positive findings, as you can see in this graph from the trial paper, was mostly driven by the French cohort. The authors has postulated why this may be the case, because the median follow-up for the French cohort was more than twice as long compared to the South Korean cohort, which were recruited later in the trial, and that may have resulted in a lack of power to detect a significant effect in Korean patients. But the average time that patients spent within the assigned therapeutic LDL range was similar, and the authors did mention in the discussion that the trial results may not be entirely generalizable to Korean patients. We have subsequently in our local registry looked into this further, right, because in view of the uncertainty as to whether the findings from the TST trial could be generalized to Asians and whether also, right, whether low LDL may also benefit patients without significant large artery disease. So we therefore studied the beneficial effects of the LDL target less than 1.8 in some of our local registries. So this was a prospective cohort of about 900 Chinese individuals, mean age of 69, 60% of men with ischemic stroke, and all of them had MRIs and MR angiograms of the intra and the cervicocranial arteries performed, and these were recruited between 2008 and 2014. And we defined those with a significant large artery disease with if they had more than 50% luminal stenosis of the intra and or the extracranial artery atherosclerosis. And about half of them had evidence of large artery disease with scanning. About a third had intracranial disease, a third had extracranial, and the remaining had both intracranial and extracranial. And during the median follow-up of about 6.5 years, patients had an average of 9 LDL readings during the follow-up period. And as you can see here from these two graphs, patients with and without significant large artery disease who achieved a average post-event LDL of less than 1.8 millimoles per liter. So the solid line, they were significantly associated with a lower risk of major cardiovascular events with a, you can see the subdistribution hazard ratio being 0.65 for patients with large artery disease and 0.53 for those without significant large artery disease. And mind you, this is adjusted for vascular risk factors, underlying coronary artery disease, history of stroke, renal function, and also a serial blood pressure during the follow-up period. So we also, of course, this was also significant for recurrent stroke as well. So other than major adverse cardiovascular events, the findings were very similar for prevention of recurrent stroke. And similarly, when we stratified the analyses by age and looked into those aged less than 75 versus more than 75 years of age, we also showed similar findings, regardless of when we stratify by age. The third part of this guideline mentions, the fact that if patients at very high risk, right, if they have a stroke with other major atherosclerotic cardiovascular disease and with maximally tolerated statins and ezetimibe, but still have an LDL of more than 70 milligrams per deciliter or 1.8 millimoles per liter, it is reasonable, right, to treat with PCSK9 inhibitors. And just to illustrate some of the landmark trials that has led to these recommendations. So first of all, the FOURIER trial. In this trial, they looked into 27,000 patients with atherosclerotic cardiovascular disease, and about a fifth had underlying ischemic stroke. They had LDL of more than 1.8 millimoles per liter and were receiving moderate to high dose statins. And they were randomized to receive everolimus versus placebo, and again with a composite endpoint of a major cardiovascular event. And you can see here during a mean follow-up of about 2.2 years, the everolimus dramatically reduced the LDL from 2.4 to about 0.78 millimoles per liter. And on follow-up, you can see that the everolimus reduced the risk of major cardiovascular events by about 15% with a hazard ratio of 0.85. But there was no increased risk of diabetes, dementia with everolimus, which has been some concerns previously. In the subsequent analysis, right, of the FOURIER trial, it was also noted that everolimus on the background of statins significantly reduced the risk of all stroke, as you can see here in some of the subsequent analyses. And of course, the majority of these were ischemic strokes. And certainly, the level of LDL reduction in individuals with everolimus in the FOURIER trial was no different in patients with a prior stroke, as you can see in this graph, compared with those without prior stroke. So, you can see pretty much identical findings in patients with and without previous stroke. And certainly, right, in the patients with prior stroke, you can see that the efficacy of reducing LDL and also the cardiovascular events were pretty similar. As you know, there's other sort of PCSK9 inhibitors. So this is the other one, the Odyssey trial, and another landmark PCSK inhibitor trial, and this studied in 18,900 individuals with recent acute coronary syndrome in the recent year or so. And they had a normal lipid profile and were already receiving high dose statins or maximally tolerated dose. They were randomized to receiving everolimus versus placebo, and again with a composite cardiovascular endpoint. And as you can see here, with a median follow-up of about 2.8 years, everolimus significantly reduced the risk of any stroke, right, and also ischemic stroke without an increased hemorrhagic risk, right, as you can see in here in these graphs. And certainly with a hazard ratio, right, of reducing risk of stroke of about 0.72 and ischemic stroke 0.73. So with these studies and various trials, there has been this is from the European Heart Journal. You can see the approximate sort of average lipid reduction, LDL reduction with different intensities of statins, right? Together with ezetimibe and also with PCSK9 inhibitors. So this serves as a useful guide as to, depending on the baseline LDL, and we see our stroke patients, depending on the vascular profile and the etiology, right, how much, the approximate LDL that can be lowered with the various combination of treatments. Having noted that, we also, with these recommendations, we also looked into a more contemporary cohort within our local population, looking into about 1,000 Chinese individuals with a TI and ischemic stroke, and about age of 70, 54 men, and these were in 2019 to 2020 with about a 2-year follow-up. And basically, we noted that about a fifth of individuals, right, with TIA, ischemic stroke, and atherosclerosis did not achieve the recommended target. And interestingly, only, again, a fourth or a fifth of them were on high intensity statins, and a very, very small proportion, minority, were on ezetimibe. So certainly lots we can do in terms to optimizing the use of high-dose statins and also additional lipid-lowering therapy. And indeed, I mean, in terms of, frequently there has been discussions as to how low should we go, right? And of course, in this meta-analysis of 23 trials involving 220,000 individuals, right, you can see that very low LDL, right, was achieved associated with reduction in ischemic stroke, and it has been calculated that for 1 millimole per liter decrease in LDL, that was associated with a reduction in risk of about 28%, as you can see in this chart, right, with a combination of a number of primary trials and also secondary preventive trials. Of course, there has always been concerns about whether if you go to a very low LDL, whether there is increased risk of intracerebral hemorrhage. And this is a very nice study from the China Kadoorie Biobank collaborative group published in Nature Medicine in 2019, using a number of approaches, looking into the China Kadoorie Biobank data, looking into the genetic studies and Mendelian randomization analyses, and also the published randomized trials. And as you can see, right, with lower LDL, there is a lower risk of ischemic stroke, but there also appears to be a higher risk of intracerebral hemorrhage. Nevertheless, right, as you can see in the right side of the PowerPoint of the slides, it has been also noted that lipid-lowering therapy is still likely to have an overall net benefit, right, in terms of prevention of overall strokes, and also importantly, ischemic strokes, right, in China, despite the sort of slight increased risk of intracerebral hemorrhage. And you can see these calculations in terms of looking into whether the patient has low risk, medium risk, and high risk. Lipid-lowering therapy is still likely going to have overall net benefit in prevention of overall stroke. A lot of the trials that has been done and mentioned in the presentation thus far has focused on atherosclerotic related strokes, and basically a lot of these trials and meta-analyses, right, has shown that there has been a significant benefits, right, with intensive LDL lowering therapy, with a reduced risk of recurrent stroke, mainly in trials with patients with atherosclerosis, but not in those not having evidence of atherosclerosis. Of course, I mean, I told you in terms of Sparkle trial that excluded patients with cardioembolic stroke, and I don't think there has been trials focusing on lipids in cardioembolic stroke. But observational studies have shown that use of statins are associated with lower mortality and also incidence of vascular events, but not for stroke recurrence. Certainly, the optimal target or the degree of LDL reduction in stroke patients without evidence of atherosclerosis remains uncertain, and we do lack and need more studies and trials with that regard. And certainly, the Chinese population, again, most of what I presented were based on trials that were done in the Western populations that has led to the international guidelines. And of course, these involved mainly white subjects. And of course, more trials looking into the optimal lipid management in Asian stroke patients would be needed. And we do know, of course, that ethnically there are differences, and from various studies, right, Chinese and Japanese are traditionally known to have a lower LDL and higher HDL compared to Caucasians, with a lower prevalence of coronary artery disease and mortality in general. And certainly the genetic profile, right, and also of course relates to the various pharmacokinetics as well, would be very different in Asians compared with Caucasians. For example, statin pharmacokinetics, right, of course, we know now a lot about in terms of the pharmacokinetics for antiplatelet and potential resistance and then so on, right? But then there has been evidence that the statin pharmacokinetics between Asians and Caucasians are different. For example, right, in terms of exposure to rosuvastatin, right, it was noted that the pharmacokinetic studies, the systemic exposure was about twice as high in Chinese compared with Caucasians. And this subsequently resulted in FDA warning that in Asians and Chinese, that statins, right, we should consider to start at lower dosages, and there should be caution if we go to a certain dose, and we may need to monitor them more closely, etc. And of course, there are also genetic polymorphisms, right, in terms of that may influence the statin pharmacokinetics, right, such as these, right, SLCO1B1 and ABCG2, right. And indeed, right, different trials have also noted that the side effects of statins may be more prevalent in Asians. And take this trial, for example, right, a multi-center trial, randomized controlled trial testing niacin, right, in China and Europe, right, and noted that with the same dose of statin, the incidence, right, of a raised liver function test, ALT, 3 times the upper limit of normal, was about 0.4% per year in Chinese, compared to about half in European patients. And similarly, the incidence of myopathy was higher, right, in Chinese compared to European patients. So certainly, right, lots that can still be looked into, right, regarding in the Chinese population and Asian populations in terms of studies on lipid-lowering therapy, in terms of pharmacokinetics, right, and so on. And certainly, I've shared with you not only the trials about the that have led to the guidelines, but also some of the remaining studies and also unaddressed questions that can be done. So I do hope that this alliance would produce more fruitful collaborations. And with that, thank you very much. And I do look forward from learning from you all in the coming meetings. Thank you very much.
Thank you very much, Professor Lau, for your wonderful talk. And it's really cover lots of information, especially updated of the clinical trial and the international guideline recommendations. So we will have the panel discussion after the key presentations. Thank you.
Thank you.
So we would move forward to our next guest speaker, Professor Andrew Wong from Brisbane and the Women's Hospital. Professor Wong is a stroke neurologist and director of the neurology and stroke at the Royal Brisbane and Women's Hospital, Australia. He has major focus on the stroke and in Australia, including the co-chair of the Australia Stroke Trial Network, which provide a lot of academic contributions. And today, he's going to give a talk regarding the lipid management after stroke. Please, Professor Wong.
Thank you. I'm just sharing my screen. I think probably this is the best way to do it. Okay, so you can see my slides, I hope. Okay. Good. Oh, hang on. Right. It says.
Not yet.
Yeah, I'm getting an error message telling me that Zoom quit unexpectedly, but I will find a way around that, I think. share a different screen. Maybe if I do it this way. How's that? Can you see my screen now?
Yes, no. It's
Oh,
good.
good. Okay. I'm not sure what happened before, but Zoom was unhappy with me. But thank you very much. Well, thank you very much for the introduction and the invitation to speak with you today. I've chosen to use my Stroke Academy slide background because I have a fair few, well, several affiliations and disclosures, but one is certainly that I run the Australasian Stroke Academy, which is a educational group formed by like-minded stroke physicians in Australia and New Zealand. We do a lot of education, and I've chosen that as my slide backgrounds today. I guess one of my most important disclosures is that I don't have the cardiovascular research background that Professor Lau has, but I was very pleased to see that although we've chosen slightly similar topics, there's a lot of overlap in what we've decided to talk about. I'll try not to repeat everything we've just heard, try to find something slightly different to talk about. We saw in the last slide deck some guidelines from the AHA and the ASA. These are the Australian guidelines, which formatted differently but tell us very similar things. One of the advantages of the Australian and New Zealand clinical guidelines, these are living guidelines. In other words, we publish them online and we don't publish them in a journal or in hard copy. So the methodology that we use allows for new research to trigger a review of our guidelines, and then the writing committee, which I'm a part of, will review the evidence and decide if a new guideline is warranted using the grade criteria. And then we can update our website relatively quickly to save having to wait for the traditional 2, 3, 5 year life cycle of a guideline. So very similar to what we just heard, we should be using high dose statins and aiming for an LDL of less than 1.8 millimoles per litre, not using statins for people who have a hemorrhagic stroke as their index event, and not using fibrates, but I'll go through that as we go. We know that lower LDL is associated with a lower risk of stroke. And we already saw the Sparkle study, and I just wanted to follow this slide up, which looks at stroke as the outcome with a hazard ratio of 0.84, with the other endpoint of interest, because our stroke patients, as we know, our stroke patients don't just have ischemic stroke as their next event after their ischemic stroke with us. They have many cardiovascular events as well. So I've focused my slides actually on cardiovascular events as the composite endpoint of interest, and given that fact. So yeah, so consistent benefit from high dose atorvastatin at 80 milligrams on the prevention of cardiovascular events in patients presenting with stroke. We also talked about the Treat Stroke TART trial, which was a new paradigm when I wrote this slide the first time, but it's becoming quite standard and not very new anymore. But in patients with an ischemic stroke, aiming for a lower target LDL, we've just heard before about the benefits that had. I'll show you on the next slide how well they did at reducing the LDL. So there was a reduction in LDL in the control arm from 3.5 to 2.5 millimoles per litre, but a lower reduction. So obviously very important when doing an intervention trial like this to actually achieve a difference in LDL levels if one's trying to show any impact on the outcome of interest. So pleasing to see that with this protocol, they were able to achieve a 0.8 millimole per litre difference in LDL levels between their intervention and their comparator arm. So how did that affect the patients? That achieved a 22% risk reduction for major adverse cardiovascular events. So I've got a table coming up where I'll try to do a bit of a cross-trial comparison of all of this, but that was pleasing to see, because until 2019, all we knew is that one medication at one dose was helpful at preventing stroke. It was never clear to us what to aim for, and it was always hard to debate with the patients who did not want to start 80 milligrams of atorvastatin what they should do with their LDL. So I think this was a very complementary study to the Sparkle study, and that it reinforced that we should be using high-dose statins, but that we should be aiming for quite a low LDL. I think it's, although there's some emerging evidence in the cardiology literature for aiming for an even lower target LDL of, for example, 1.8 millimoles per litre, but I think with a standard of care of a target of 1.8, it will be difficult to design a trial that shows incremental benefit of aiming for 1.4 millimoles per litre in a stroke population. Well, it would be easy to design the trial. It will be difficult to execute the trial because the number of patients that we would need would be very high, I think. The PCSK9 inhibitors, I put a slide in to remind myself why they work. So PCSK9 stands for this hepatic proprotein convertase subtilisin kexin 9, so PCSK9, on a background of hepatic and other LDL receptors, removing the LDL from the circulation, leading to a lower LDL level. So that's what they normally do physiologically, and then PCSK9 normally inactivates those LDL receptors so they can't remove LDL from the circulation, which leads to higher LDL levels. So our pharmacology, the PCSK9 inhibitors, they prevent that from happening. So there are more LDL receptors to remove LDL from the circulation, leading to lower circulating LDL levels. So quite a neat and elegant way of reducing circulating LDL levels. We've seen this slide, so probably the only thing to mention is the 1.5 millimole per litre reduction in LDL level, which achieved a 15% reduction in cardiovascular events. So probably no need to revisit that data. I was interested to see that there were the same sub-study that we saw before about what happens in our stroke patients, because the parent study, the FOURIER study, was a group of patients with a variety of index events, which enrollment criteria. But this sub-study just looked at the stroke subgroup, and again, in that group, the benefit seen for this cardiovascular event outcome was consistently seen. So I put all the numbers together on a slide, although we all know about cross-trial comparisons, but we're not trying to show that one's better than the other. In fact, as I said, the Sparkle and the Treat Stroke to Target trials are very complementary, and the FOURIER trial isn't instead of atorvastatin. It was on top of high-dose and medium-dose statin therapy. So the first 4 rows are really just data as presented in the trial. And on the right column, some of that data is from the Gugliano sub-study of stroke patients from the FOURIER paper. So just putting both in millimoles per litre and milligrams per deciliter what the LDL was at the start, what the LDL was at follow-up in the control arm, and what the LDL was in the intervention arm, and the absolute differences there. And we can see that reasonably similar differences in LDL reduction, but on a very different background of controlled treatment. Nevertheless, a relatively similar reduction in major cardiovascular events. So what we're seeing is that the advice that we're giving to our patients, based upon these 3 major trials in prevention of cardiovascular events in stroke, the advice seems to be consistent in terms of ability to reduce major cardiovascular events. With some number crunching, because it wasn't easy to see from the trials, but the number needed to treat is also interestingly consistent. So we're talking about 150 patients with stroke needed to treat for 1 year to prevent 1 cardiovascular event. So that's not an easy number to rationalize in a clinic, because we don't treat with statins so often that we're going to see this in our clinical practice. Even if we treated dozens of patients a week, we don't, obviously, find out about the strokes that did not happen. So nevertheless, on a population basis, this is incredibly important. So 150 patients treated to prevent 1 event there was one economic analysis of the impact of stroke in Australia, which estimated over 400,000 stroke survivors in Australia alone. And Australia only has a population of 26 million. So the benefit across a population in Hong Kong or in China or United States or elsewhere is exponentially higher, literally by an order of magnitude. So we could certainly see that as a overall treatment strategy, statins and the reduction of LDL to a certain target and the use of evolocumab can be quite effective in preventing cardiovascular events. The bottom two rows are just to highlight what the treatment was in these trials, and atorvastatin 80 obviously was the statin used in Sparkle, but most of the patients in the intervention arm in Sparkle and in the FOURIER trial did use high intensity statin, which includes atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40, and there's other combinations which fit into that category. So just as a segue to the next slide, there was some ezetimibe usage in treat stroke to target and in FOURIER. Couldn't find the protocol for the Sparkle study online, but I presume it was zero because they were doing a cholesterol intervention trial. So what do we know about ezetimibe? We've heard some of this as well. As monotherapy, it does have an impact on LDL levels, and in the IMPROVE IT study, both in the parent study within 10 days of acute coronary syndrome and also in the stroke subgroup, we saw a benefit in stroke prevention incrementally on top of statin usage. And so there was certainly some evidence for the use of ezetimibe. There's not very much data beyond that in the prevention of events in stroke populations, but certainly enough to be enough to warrant a guideline into using ezetimibe in clinical practice. This is unfortunately the result of a lot of work looking at fib rates and basically demonstrating that there is no prevention of cardiovascular disease and stroke in patients with stroke or other cardiovascular events. So our guideline in Australia says that we should not be using fib rates for routine secondary prevention of stroke. Just a few words about hemorrhagic stroke. That's always been a concern. I guess there's a higher prevalence of hemorrhagic stroke in the Asian population than the Caucasian population, but it was I guess it was a disappointing finding in hindsight from the Sparkle study, showing an increase in hemorrhagic stroke overall, especially driven by hemorrhagic stroke in patients presenting with hemorrhagic stroke. I say disappointing for two reasons. One is that subsequent studies haven't really shown this, and secondly, there just doesn't seem to be any, in my mind at least, any biological plausibility for why atorvastatin at 80 milligrams would prevent stroke in hemorrhagic stroke patients. So I'm not sure why they were enrolled in the study, but in any case, the take-home message is obviously that if patients present with a hemorrhagic stroke as their index event, we should not start statins to aim to reduce LDL. And I don't know any clinicians or guidelines that would suggest that is a reasonable thing to do. And also, that means that the meta-analysis that uses the Sparkle study will carry along this increase in hemorrhagic stroke with it, but nevertheless, the stronger prevention of ischemic stroke certainly outweighs the slight worsening of a hemorrhagic stroke. Consistent with that, just looking at the bigger trials that are specifically in stroke patients that we just talked about. So in the treat stroke to target trial, so no signal that there would be more intracranial hemorrhage. In fact, the percentages are actually lower for the higher target group. Clearly not statistically significant, but no signal there that there is a increased risk of hemorrhagic stroke just by reducing LDL to a lower target. And in the FOURIER trial, again, for hemorrhagic stroke as the endpoint, no signal to suggest that even getting the LDL down to 0.7 millimoles per litre, or around 30, I think that's 30 milligrams per deciliter, but even getting the LDL down a very long way still does not lead to hemorrhagic stroke in our patients. So that's very reassuring when we are usually, some of our patients will be eligible for and be prescribed evolocumab, but usually we're dealing with statins and ezetimibe, and the achievable LDLs are nowhere near this. It's very reassuring to me that it's very unlikely that that's going to lead to an increase in hemorrhagic stroke in those patients. So that's all in line with the cholesterol treatment trialist collaboration and the American Heart Association, which all of these bits of text are cut and pasted out from various publications, but basically concluding that statins do not significantly increase hemorrhagic stroke risk. I know there will be some discussion forthcoming about the role in intracranial atherosclerosis, and I don't think there's much, and I'm very interested to hear if there's more. But I found a couple of papers looking at asymptomatic intracranial intracerebral arterial stenosis and symptomatic, and certainly there's some signal to suggest that the degree of stenosis can be reduced, which is very interesting to me because I don't see a lot of ICAD in my population in Brisbane, Australia. Most of my patients are Caucasian, but I am aware of the lack of any evidence for what to do for those patients. There's certainly no evidence from the WASD trial and other trials that anticoagulation is not the right thing to do beyond antiplatelet therapy. There's also the stenting trial telling me that stenting is not helpful. So it's nice to see that there might be a suggestion that intensive LDL lowering might be one therapeutic option. And the other issue for my patients, I guess, is that when patients have ICAD, there is an issue with thromboembolism and embolic stroke, but I also have patients who have hypoperfusion TIAs, and it's some of those patients. It's nice to have nice to be able to tell them that if we bring their LDL down, then they may be able to improve the perfusion of that symptomatic tissue and prevent their hypoperfusion TIAs. Not that commonly a problem or an issue for me, but nevertheless nice to know that if I give them some advice about intensive LDL reduction, there might be some evidence to suggest that's good advice. A couple of slides on safety. So I didn't show the table from the Sparkle study, but there was not an increase in muscle problems, rhabdomyolysis or muscle-related events in the Sparkle study. And similarly in evolocumab, even with that very low achieved LDL, no signal that there was increase in muscle-related events or rhabdomyolysis in the 4-year study. And again, we briefly touched on this in the previous talk, that even with that very low LDL reduction and the concerns about the role of lipids in generation of myelin and neural tissues, that cognitive function was not affected in the Fourier trial. So just a summary of what I've said, we really should aim for an LDL of at least 1.8 millimoles per litre, using a combination of statins and PCSK9 inhibitors as necessary. With ezetimibe, might or might not be helpful, but I always add it in as well, and certainly that's part of our prescribing criteria for PCSK9 inhibitors in Australia. We need to do that before we can prescribe those. Fibrates do not help. Even with very low achieved LDL levels down to 0.6 millimoles per litre, there's no harm. So that's very reassuring. More hemorrhagic stroke in one study, but still net benefit, and no other studies suggesting that there's a problem if we bring the LDL very low with statins, ezetimibe, and PCSK9 inhibitors. As an aside, LDL lowering is not useful for hemorrhagic stroke patients, but as a practical point, I am interested about people do things differently. But if my patient presents with an atherosclerotic event and has a prior history of hemorrhagic stroke, I still prescribe statins and aim for the same LDL lowering levels. I think the index event being atherosclerotic in that case supersedes any concerns about causing hemorrhagic stroke with lipid lowering. One point about stroke and cardiovascular events being prevented in patients presenting with ischemic stroke, and some interesting ideas about LDL lowering, improving intracranial stenosis. But again, the clinical effects are not clear, so I'm not sure how well that translates into embolic or hypoperfusion, TIAs, or strokes. Thanks very much. I'll stop sharing.
Well, thank you so very much, Dr.